Okay, I think we're on to something here. So, good morning, good afternoon, good evening to each and every single one of you. Thank you very much for your patience. I'd like to take this opportunity to welcome you to our monthly, and this is the first one for 2026, but our monthly Massachusetts General Hospital um, Global Health and Gastroenterology Educational Series, Global Gastroenterology. And part of this, series is to hopefully educate individuals, patients, non-patients, healthcare professionals on different aspects of GI. And we try to bring to you various speakers of different expertise within the field of GI. So if you have a topic you're interested in and you don't see it on our upcoming list, feel free to send me a message and we'll be able to help you. Um, the program is CME. And so when we start off, I'll show a couple of slides on how you can get your CME. So you get some CME points for attending the session today. I'm Dr. Akwi Asombang, in case I didn't introduce myself early on, and I am an interventional gastroenterologist at Massachusetts General Hospital. And I'm also the director of the MGH Global Gastroenterology Program. And I look forward to hosting our speaker today, Dr. Moinak Sarma, and our MGH Global GI volunteer, Angela Atek, is here with us, who's a medical student in Egypt. And who's not here with us is Dr. Kiza Brown, who's also one of our MGH Global GI volunteers. She's an internal medicine resident at Massachusetts General Hospital. So in terms of our speaker, most of our speakers have some sort of connection. So Moinak and I have a connection. We were med students together. So he's my classmate from med school. For some of you and I went to med school in India. We were med students together in India many, many, many years ago. And leading up to this, I knew he was a gastroenterologist. And so, as with most, we've got a WhatsApp chat for the class. And he was always getting like all these awards, which, was not a shocker. But I think it was only recently, maybe in the past year or two, that I actually realized, and we texted about it, that he does interventional GI and peds, which is a big deal. And then today he reminded me we do have another connection, that we actually went to the same school in Zambia. It was different time periods, but we both went to ISL, it's known as International School of Lusaka. And then, in addition to that, we were both in Kenya, probably around the same time, or we switched places somehow. But we were both in Kenya. He was in Mombasa. I was in a different part of Kenya. But he was just reminding me our other connections, in addition to the fact that we're med school classmates. We were both in Zambia. I mean, I'm Zambian Cameroonian, but we both went to school in Zambia and in Kenya. So it's an amazing world when you make these connections. On a personal note, I am very, very grateful for his time. We went back and forth in terms of just trying to finalize it. When I asked him to present, he immediately said yes, and we just needed to figure out what time would work best. And so I'm very grateful that he's taken the time to present to us today. The topic is really, really important. Sometimes when you think of children, they're not just little adults. My foundation training is medicine and pediatrics, but sometimes children present differently. I perform procedures both in adults and then the specialized procedures in children, but it's always good to have an expert like Dr. Sarma who present and discuss, what's so unique about the children, how they present, how we perform these procedures. And there's an opportunity for you to ask questions. So please feel free to ask questions in the chat, or you can raise your hand. I am going to share a slide, and the first slide I'm sharing, I'm going to share his slides, but the first two slides are basically how you can get CME. So maybe take a screenshot of that. I have posted this publicly on social media as well, but please feel free to take a screenshot. Let me share it now. Can you see my slides? And I'll put it in presenter mode shortly. But can you see my slides? Okay, so presenter mode. Okay, so these are the slides. This, as I mentioned, is a CME program. So please feel free to take the number, scan the code, and we will get right into it. So Moinak, a big, big, big thank you for your time and dedication. Truly appreciated. Just let me know when to move to the next slide and I'll be ready to go.
Okay, thanks, Akwi. This is really an honor that you've invited me to present pancreatic diseases in children. And as Akwi said, we go back many years when we were med students together. And I think one of the important features of Akwi was that she was a great basketball player as well. And and the boys would really be scared of her because she would outrun them immediately. So, without wasting much time, these are pancreatic disease in children. Akwi, feel free to stop me if I'm overshooting time, okay? So, how do I operate my slides?
Oh,
Okay.
I would have to share them. Because you'd have to tell me when to move since I was the one who downloaded. I don't think there's a way you would be able to
Okay.
share it.
Okay,
Um, yeah, so just
the
tell me when to move and I'll go to the next one.
okay, so the next one, please.
Yeah.
Okay, so for the international audience, where do I come from? So this is we're about 500 kilometers east of New Delhi, and this is a place called Lucknow. And if you're wondering where the Taj Mahal is, and that is in between New Delhi and Lucknow. And 500 kilometers east would be about 350 miles. So that would be somewhere between, say, where you are at Boston to, say, Philadelphia. That's the distance between New Delhi and Lucknow. Okay, so next slide, please. Okay. So this is my institute, and we are a tertiary referral center, and we have about 10,000 outpatients in my department per year, about 1,200 admissions in the year, 2,500 endoscopies, and we do about 6 to 8 US in my department with 10 to 12 ERCPs. And we also have the highest training program in the country, and that is the DA in pediatric gastroenterology. And these are some of my students, and we also run a PhD program. Next slide, please. So this is Akwi and I. We're at our 25-year reunion, and these were the boys I was speaking about who would probably, she would outrun them in basketball. Okay, so next slide. Okay, so when you look at, when you have three kids, okay, the eldest one, you can play the slides, Akwi. So the eldest one is usually the one that takes the limelight, and he's the leader. And you have a lot of hepatologists around liver. The lumen is basically a compromise, and he's usually always negotiating, mediating. The pancreas is always an attention seeker, is always insecure. He's not getting too much attention. And right now, we need a few gastroenterologists. Next slide, please. So we dire need of pediatric pancreatologists who can do good work in the society, and pancreas is like a volcano. The overview for this seminar is that we're going to run through acute pancreatitis, recurrent, acute, and chronic, and we're going to look at the role of EUS and ERCP, and if time permits, we're going to look at trauma and pancreatic insufficiency to cover everything. So acute pancreatitis, if you look at the epidemiology, we have some terminologies that we have to be familiar with, because in epidemiological studies, they just don't talk about incidence and prevalence. They look at the age standardized, they look at the disability adjusted life years, and they look at the average annual percentage change and the estimated annual percentage change. So we won't get into the details of how to calculate this, but then we'll just give you a basic idea. So there are about 3 to 13 cases of pancreatitis for every 100,000 patients, as compared to 5 to 60 in adults. The age is about 11.9 years, and you have two peaks, one at the just the preschool, and then you have the adolescents, and 15 to 35% would progress to ERCP, RAP and chronic pancreatitis. If you look at the overall average annual percentage in children, you would see that except for Qatar, which is reporting a decreasing prevalence of pancreatitis, the rest of the countries around the world, United States, Brazil, Western Europe, and Australia are reporting very high increasing rates of pancreatitis, more than 3% per year. So the next slide, please. So the lifestyle risk is the most important one, and they looked at 34 studies across children, and they found, children and adults, and they found that there is an increasing incidence between men and women, so it's not different between the two, and an average annual percentage change of 3.07% with time. And they found that the biliary and the alcohol-induced pancreatitis have significantly increased with time. The most alarming is North America and Australia. Look at 1960s all the way up to 2015. It's just bursting in North America and Australia. The problem is that the age standard prevalence rates is the highest in Russia and the Balkans, and I'll tell you why that is so. But the rest of the countries, like China and probably Africa, doesn't have too much of registries to report. But China reports now lesser pancreatitis as compared to before. If you look at the annual incidence rate, it is the worst after Russia, is the worst in India and Japan for some reason, and it's just getting worse with time. When you look at the AAPC of the the age standardized prevalence rates, you would see that the worst performing countries is North America, USA, and also parts of the Balkans and Russia. If you look at China, China is reporting lesser pancreatitis as compared to before. Next slide, Akwi. And if you look at the incidence, it's the same. Now, when you look at the the disability adjusted life rates, you would see that it is decreasing from 1990 all the way to 2019, both in men and women. And these are the ages at which it can occur. So less than 5, 5 to 9, 10 to 14, and 15 to 19. So overall, it's decreasing. Next slide. The mortality is also decreasing in the same proportion. Next slide. But if you still look at the disability adjusted life years, you would still see that the worst performing countries are Latin America, that is Brazil, as well as all the African countries, most of the African countries. Next slide. The deaths are also higher in these countries, but China reports lesser deaths as compared to before, and Greenland is looking happy with the blue color. I don't know how long it will be happy, but then it has lesser pancreatitis as compared to before. Next slide. So now we have prediction models, and they say that the incidence of pancreatitis presently is about 300,000, but it's going to, another 13,000 are going to add on by 2040 per year, and the highest is in South Asia. Right now, we have an annual standard incidence rate of 8. It's going to increase all the way to 9, and it's going to be highest in the Eastern Europe. But they predict that as your hospital care is getting better, your disability adjusted life years are also going to get better. By 2040, it's going to come down. That's the prediction. Next slide. So the countries and the trend that's happening. For Brazil and Chile, there's a very fast rise. We don't know why, but they suspect it's because of smoking and narcotics amongst adolescents. In China, there's a very fast decline. It's because of better referrals, and they have lesser alcohol. In Russia, there is a high incidence, and that incidence is because of an alcoholic consumption and binge drinking that's in vogue, and that's there in Russia and Balkans, and this is all in young age groups. And in India, we have a very bad Delhi and a very bad AAPC that's because of poor healthcare systems, ascariasis, and poor hygiene. So the messages from epidemiology is that we have rising global trends. There's no sex predilection. Western countries, it's attributed to the lifestyle changes. And for the Delhi and mortality, it's the low socio-development income countries. Let's look at the etiologies. So the dilemmas of referral in the lower socioeconomic countries like ours, and probably lesser in Africa, is that we have We don't know how to assess the pain. We have an alarmed family. We have the natural history on the first few days. We don't know whether it's resolving or progressing, whether we have enough infrastructure for investigations, how to look at complications, setup, and support. And there are assault on doctors, litigation, and persistent night calls that make life very difficult when you have cases of acute pancreatitis. Next slide. If you look at the etiology, then the pooled data would say that the median age is 7.4 years. Most of the cases are idiopathic. Then you have trauma, drugs, infection, structural changes, and systemic causes as well. Next slide. So when you look at the causes in the tropics, you have problems of acute viral hepatitis. That is about 5 to 6% of all viral hepatitis have acute pancreatitis. Then you have hepatitis A or E as one of the causes. Most of them are mild. They have resolution in all. But sometimes especially in India and the sub-Himalayan belts, you have something known as ascariasis, and that can get into the bile duct, that can get into the pancreatic duct. Most of them are mild, some of them are severe, and there is a reported mortality of 3%. Next slide. Okay, so this is a 16-year-old girl from rural North India. She's a known case of chronic pancreatitis, and I've been doing there's a head stricture, and I've been doing the ERCP in this patient. She's had 5 sessions, and then she comes, pancreatic duct clearance, and then she comes with a recurrent biliary colic for 10 days. Next slide. Akwi, can you play the video here yeah. So what do you see? You see 2 stents, and you see a worm that's lodged inside the ampulla. We don't know where it's going. Most likely, this is going into the bile duct. It could be going to the pancreatic duct as well. And look at that, there's another worm that's trying to get in, and that's moving, it's wriggling. You would see that the moment there is bile, it starts to sample the bile. And we'll tell you why. The Ascariasis likes an alkaline environment, and that's why it's trying to get into the duct. So this is a husband and wife who are probably having an intimate moment inside the bile duct. And with the pancreatic stents in situ, we're trying to take these worms out. We extract them with forceps. Okay. So here we are, we're taking them out. We just have to tug them out. There's no other way. And it's always nice to intubate these patients because you don't know whether it'll lodge into the respiratory system. So here we're getting into the bile duct because I think there are more. You see the worm? You see the worm that's lodged in the biliary tree? This is a worm. This is a third worm that was lodged in the biliary tree. So we took out 2, and now we'll do a balloon sweep and take out the third worm out. So this is a family that was inside. And okay, so then we're doing the balloon sweep here. Yeah. Right. So we extract the worms. And look at the size of this worm. It's 28 centimeters. It's a huge worm. Okay, there were 3 worms, and the largest one was 28 centimeters. Next slide, please. Okay, so one of the risk factors for pancreatitis, pancreatobiliary ascariasis is the large size of papilla. If you've had a prior sphincterotomy done, or if you've had a cholecystectomy, then there is a CBD dilatation and there's a relaxation of the sphincter of Oddi. Next slide. The problem in pancreatitis, in biliary ascariasis, is whether we should give an antihelminth prior to doing the ERCP, because the moment you give the antihelminth, it's going to kill the worm, and that becomes a nidus for stone. And the worm, when the worm is dead, it's very friable for extraction. You can't sometimes take all of it out. And if you do a sphincterotomy to allow accessories in, then you'll also allow more worms to get in. But the second option is a better option because you have to get the worms out and you have to put these patients on regular antihelminths. Next slide. So the other the other problem in our part of Asia is dengue. And dengue has a biphasic illness. It has fever in one part, and then it has anasaka followed by thrombocytopenia. Next slide. And a large proportion of these patients also have jaundice and transaminasemia, and they can rarely get into liver failure. But what happens is, in the next slide, what happens is that some proportion of patients also have a dengue pancreatitis, and that is 15 patients of all dengue. And dengue is very common in Asia and Latin America. It causes capillary leak, ischemic pancreatitis. 65%, two-thirds of them are interstitial, but one-third can be necrotic pancreatitis, and 25% actually have, one-fourth of them have multi-organ dysfunction. So the messages is, we have, from global point of view, viral, biliary, trauma, and idiopathic. The low socio-development countries have dengue, hepatitis A, E, and ascariasis in addition, and young patients can have systemic or inborn errors of metabolism as one of the causes. Next slide. So just like adults, we also rely on the revised Atlanta definition. So you have the edematous interstitial pancreatitis and you have the necrotizing pancreatitis. The edematous pancreatitis is definitely much better. Next slide. And we also categorize, just like adults, into mild, moderately severe, and severe. Mild would mean no organ failure, no systemic local complications. Moderately severe would mean transient organ failure with local or systemic complications. Severe would mean persistent organ failure more than 48 hours. When you look at local complications, you have acute collections, and you also have some local complications such as gastric outlet obstruction, splenic vein, and portal vein thrombosis, and it can also lead to colonic necrosis. Next slide. So how to describe these collections are less than 4 weeks. If it's interstitial, you would call it acute peripancreatic fluid collection. If it's more than 4 weeks, you would call it a pseudocyst. But if you have a necrotizing pancreatitis less than 4 weeks, you would call it an acute necrotic collection. If you have it more than 4 weeks, it's a walled-off necrosis. When should we suspect complications? When you have a persistent recurrent abdominal pain, when you have, in a case of pancreatitis, when you have secondary increases in the serum pancreatic enzyme activities, when you have an increasing organ dysfunction, or when you have clinical features to suggest that the patient is going into sepsis. Next slide. So here are just some examples. This is an acute interstitial pancreatitis. On the left-hand side, you have an acute peripancreatic collection on the right-hand side. Next slide. Here are walled-off necrosis, and we've done a catheter drainage, and the necrosis has disappeared thereafterwards. Next slide. Here you see an IVC thrombosis, which is very uncommon. It's not very common, but it can lead to a Budd-Chiari syndrome, which can superimpose on your pancreatitis. Next slide. So this is a case where there was a walled-off pancreatic necrosis with an internal bleed due to a rupture of a splenic artery aneurysm, and we had to do a coil embolization of the same. Next slide. Here you have a child who's had a pancreatic pseudocyst perforating into the duodenum. And this child, we lost this child, okay? He was a 15-year-old child with substance abuse and addiction. He was on narcotics as well, and we couldn't save because he went into a multi-organ failure. Next slide. So when you look at the natural history, the mild edematous form has very little organ failure, 10%. But the necrotizing form, which is 15% of all pancreatitis, the organ failure is about 50%. Most of them are sterile necrosis. Some of them are infected necrosis. And lethality, if you have an infected necrosis, is going to be double that than the sterile necrosis. Next slide. Next slide. So let's look at recurrent acute pancreatitis. So patients who move from acute pancreatitis to recurrent acute pancreatitis or chronic pancreatitis, one of the most important etiologies is hypertriglyceridemia. And hypertriglyceridemia, 33% of them move from acute to recurrent acute. followed by idiopathic biliary trauma. Next slide. So when you look at severe and mild, the severe ones are the ones that are likely to have more recurrent acute pancreatitis than the mild. Next slide. And if you look at all the etiologies pulled together, then 35% of recurrent acute will actually go into chronic pancreatitis. Next slide. Amongst the other etiologies, you would realize, and this is a forest plot, that the anatomical abnormalities in children, the recurrent acute pancreatitis goes into recurrent acute. Contrary to the popular belief that pancreatic divisum is a cause of a recurrent acute pancreatitis, and we always mention it as one of the most important cause, this particular systematic review could not demonstrate in the forest plot that the pancreas divisum was a cause of an acute to recurrent acute. And then you have family history, genetics, which didn't contribute. Then they looked at males, they looked at sex, pseudocysts, whether that would predict, abdominal pain, fluid collections, vomiting, diarrhea. None of them predicted whether a patient is going to move from acute pancreatitis to recurrent acute. Next slide. If you look at recurrent acute to chronic pancreatitis, then the pancreas divisum and the PRSS1 mutations are the only two that would move away from the forest plot and show that they have some connection from recurrent acute to chronic pancreatitis. And obviously, those patients who have a biliary sphincterotomy done, biliary stents put in, pancreatic stents put in, are likely to have a chronic pancreatitis than a recurrent acute. Next slide. They could not, next slide. Yeah. Okay, so they could not show any demographic or biochemical risk factors between acute pancreatitis, recurrent acute, or chronic pancreatitis. And this is one recent systematic review that has just come out. When you look at risk factors and the time lag, how fast do patients move from acute pancreatitis to recurrent acute, they would see that 62, two-thirds of them would have the next episode by the fourth month, and almost all would have by 20 months. That means in 2 years' time, if you've had to have a recurrent acute pancreatitis, you would have had it for sure. And anatomical abnormalities will have the highest, and viral will be the lowest. Next slide. What happens when you give PERT, that is pancreatic enzyme replacement therapy? So this is a very nice study in American Journal of Gastroenterology in 2024, where they had 356 children, of which 76% had acute recurrent pancreatitis. 60 of them received PERT, and they saw those patients who were on PERT had delayed recurrence of pancreatitis in the follow-up, and they found that the lesser occurrence of acute pancreatitis in follow-up were those linked to those patients who had a SPINK mutation, and also the annual incidence rate decreased from 3.14 to 0.7 in the years to come. Next slide. The PRSS and the SPINK mutations are commonly associated with the chronic pancreatitis as compared to acute recurrent pancreatitis. The rest of the causes, which are obstructive, autoimmune, and toxic, were not different between the two groups. So this is the JAMA study that I'm talking about, and the JAMA study very clearly showed that patients with chronic pancreatitis will have more episodic pain scores in the future, and they would, and irrespective of any level of episodic pain, and they would obviously have worse disabilities as compared to the acute recurrent pancreatitis. Next slide. Obviously, no-brainers that the ERCP is going to be higher required in chronic pancreatitis. They are going to require more of EUS. And if you look at the CT and MRI findings, then the pancreatic atrophy, calcification, ductal irregularities, pancreatic duct dilatation, and lesions in the pancreas are going to be definitely more common in chronic pancreatitis and not in acute pancreatitis. Acute recurrent pancreatitis. Next slide. So the most prominent ones were the pancreatic duct obstruction, the dilated CBD. If you find a cyst or a pseudocyst, then it's commoner in chronic pancreatitis as compared to acute recurrent. And if you look at the abnormalities of the pancreatic duct, if you have side branches, if you have calculi, definitely much more in chronic pancreatitis as compared to acute recurrent. In fact, why should an acute recurrent at all have intraductal calculi at all? Right, next slide. The treatment is no different. How we treat acute recurrent and chronic are almost similar in terms of medication. They will all require pain medication. They will all require medical therapies. Some of them will require pancreatic enzymes even in the acute recurrent patients. They have tried steroids in autoimmune pancreatitis, but I personally don't have any experience on the same. Endoscopic procedures are definitely going to be higher with the chronic pancreatitis as compared to acute recurrent, and surgical procedures definitely are going to be more with chronic pancreatitis. It's interesting to note, next slide, it's interesting to note that the total pancreectomy or the islet cell transplants were also performed in this JAMA study. The pancreas gene panel is something that we have started doing frequently in children, and this is a nice study in pancreatology that has looked at 8 genes, and 8 genes are the PRSS1, the CPA1, FTR, CTRC, and the SDBS, which is the Shwachman-Diamond syndrome candidate genes. So, next slide. So, what happens in these conditions is that somewhere or the other, through some pathways, either by enhancing or decreasing the calcium, by enhancing the trypsinogen or decreasing its degradation, the trypsin gets activated by the SPINK, CFTR, CTRC, and the CSAR, and the PRSS1. If you look at the acini related are the ones are PRSS, SPHINK, and the CSAR. And if you look at the duct ones that are going to cause pancreatitis, it is the CFTR gene, which is going to be abnormal. Next slide. So the genes that they have shown, which have some, the previous slide, please. Previous slide, please. So the SPHINK one has faster progression to acute recurrent pancreatitis as compared to the PRSS1 and the next slide, please, or the CFTR genes. Next slide, please. But when they looked at, next slide, please. So when they looked at progression to chronic pancreatitis, they saw that if you have more than one gene, any more than one gene, the chances of you going into chronic pancreatitis is definitely faster, whether it's PINK, CFTR, or PRSS. Next slide. If you look at the course of chronic pancreatitis, then the age of onset with PRSS and SPINK1 is just going to be the same, 13 years and 12 years. The probability of hospitalization is also going to be the same across both the genetics. But the ductal dilatation is definitely higher with SPHINK1 in 10 years' time as compared to the PRSS1. And the requirement of surgery is going to be equal with both PRSS and the SPHINK mutations. Chances of developing diabetes mellitus is about 6% in 10 years for PRSS1 and 28%, 30% in 25 years. Next slide. Okay, this is an INSPIRE study, and INSPIRE is the International Society for Pediatric Pancreatitis, and it's based in North America. And in this, they have shown that their patients with chronic pancreatitis, about 75% of them require pancreatic enzymes, and an ERCP is performed almost in 3/4 of the patient. Most of them require sphincterotomy and a pancreatic stent. Interestingly, the total pancreectomy and an islet cell autotransplant is also performed in almost 30% of their patients. That means to say they have a severe disease in North America. Next slide. Okay, here is one of my patients. Sarcopenia is a major problem in chronic pancreatitis. They lose so much of weight because the pancreatic juices are just going to flow out. This is a patient who's had a walled-off necrosis, an internal bleed. You can see the bleed inside. You have a stone sitting in the main pancreatic duct, and the duct has blown out from the tail into a large collection, and we drained it with a drain, and a radiological drain, and we put him on a nasojejunal tube because he had so much, he was not able to feed at all, and that resulted in sarcopenia, and sarcopenia is a major problem in chronic pancreatitis. Next slide. So the messages are that 18% of acute pancreatitis move to recurrent acute, of which 35% move to chronic pancreatitis. If you look at acute to chronic, it's about 10%. Most common etiologies are hypertriglyceridemia, idiopathic, and biliary. Most of the severe acute pancreatitis will have recurrent acute in the long run, and the risk factors of developing chronic pancreatitis are pancreas divisum, PRSS1 mutation, and structural anomalies. Next slide. Let's look at ERCP and EUS. So I think in my panel, in one of my colleagues, Dr. Athra, is there in the session, and she's also listening to us very carefully. Yeah, she's raising her hand, and she's an excellent endoscopist, and though she's junior to me, I learn a lot from her. We discussed about the tricks and hacks of doing the endoscopic retrograde pancreatography. You need a good sedation, proper intubation, and sometimes in our country, you don't have the anesthetist available for intubation, so we do all our patients on propofol. Remember, children have a short, narrow duodenum, so you avoid an extreme right turn, when you pull your scope back. Instead, you turn the small wheel to the right very carefully, very slowly. You turn to the right, gradually move yourself towards the patient once again. Because they have a very small papilla, they would have a tapered tip. You must always have a tapered tip cannula with you, but sometimes the tapered tip cannulas can give rise to a little bit of trauma because it's got a pointed end. And always keep yourself in the right position, because if you poke too much with too many cannulation trials, you're going to end up with an early edema and a bleed, and you're not going to be able to cannulate well. Because children may have narrower passages, always keep, in addition, the 0.018 guide wire, which is the thinnest guide wire. If you are unsuccessful in the first attempt in crossing the entire pancreatic duct, then you should be able to put a 5 French stent and come out so that they don't have pancreatitis, post-ERCP pancreatitis. I always keep an adrenal flush ready because sometimes I may have cut too deep and there may be a small bleed, and I always keep the adrenaline flush ready. Air versus carbon dioxide, most of us do it on carbon dioxide, but in the initial training years, the air gives nice distension for you to maneuver your scope well. As you learn the technique, it's always nice to do your procedures in carbon dioxide because patients have post-procedure a lot of distension. Okay.
Hi, Moinak. We suddenly lost you and cannot hear you. Not sure what happened, or I can't hear you.
Akwi, next
Yes,
slide. Can you hear me?
yes, I can hear you now. I can hear you now.
Yeah. So so look at this. I've enlarged this picture. One of the flanges have gone and got stuck in one of the side branches. Next slide, please.
Hmm.
Okay. Look at the distance between, so the stent has actually gone in, it's migrated inwards, and one of the flanges has got stuck in the side branch, and we were not able to remove this stent despite so many sweeps and balloon sweeps. And we finally had to ask the adult to help us, and they used the the Sohender stent retriever, and that usually screws into the stent and pulls the stent out. Okay, so what was a simple anatomy became very complex. Look at this complex anatomy. Here's a tortuous duct, and the duct is wider than the scope. It's almost as big as the jejunum. And the one on the right side, look at it. This is packed with stones. There's an acute bend. There's narrowing beyond the body. And next slide, my guide wire is getting stuck inside it's just coiling inside. It's not able to go past the stone. So this was a complex anatomy. Next slide. Okay, here we have a long head stricture, and I have been somehow able to dilate the stricture and put 2 stents there. ASGE recommends you put 1 stent, try it and see, and if you are unsuccessful, put a metallic stent, then a double stent. That's what ASGE tells us, okay? Here is a guide wire that was persistently going into the side branch, and here is a guide wire that was wanting to go only into the cyst. Next slide. Okay, so this is the guide wire going to the side branch. Next slide. Okay, so it would either go this way or that way. It would not just go straight into the duct. So these were some nuances that we have while we do ERCP. Next slide. Okay, here is a massive head calculi, and you require something known as lithotripsy to break this up and then clear the duct. Next slide. Okay, this is a minor duct cannulation. This is a pancreas divisum where you have to go through the minor duct, and this is by the long loop. But the one on the side is where I had an ampullary restriction. I just couldn't cannulate, so I went through the minor duct and drained the duct again through the long loop. Next slide. Okay, I would have shown this video. Can you play this video? Is it possible? Oh, yes. So this is contributed by my friend Athra from Mysore. She's an excellent endoscopist. Here you see the major papilla, and she's trying to identify in a pancreas divisum the minor papilla. So she's going to show you how to do a minor papilla stenting. Okay, so here's the major. Here is the minor. She's identified the minor, and she is taking out her sphincterotome. You see the guide wire is just a little out. She put the guide wire inside. Now she's putting the sphincterotome inside. She gradually goes in. You should be very careful here because this is not a very stable position. Yeah, so she's gone with the guide wire in all the way to the end of the pancreas. And very gradually, she's going to make a very small cut there. Yeah, you see, here is a small cut, sphincterotomy she's doing. She's made a very little cut, just about a millimeter or 2, okay, not more than that, okay. She's been very, very careful because the duodenum is sitting right there. If she cuts too much, she may perforate. So now once she's done that, she's put the guide wire in, and once she's put the guide wire in, she's putting her stent inside. Wonderful. This is a wonderful demonstration of a minor papilla stent. Stenting. The stent is quite long, but then she probably wanted to go all the way to the end of the pancreas. And this is quite a long stent, and you can see some of it hanging inside the duodenum. But this is an excellent demonstration of what minor papilla stenting can do. And this can do wonders for pancreas divisum because it's almost therapeutic. You know, you're just you're just giving them a nice cut. Next slide. Okay, so here, Akwi, this is a question for you, okay? So here we have a 1-year-old boy who has chronic pancreatitis, possibly genetic, and he has a pancreatic ascites, and we also have an extrahepatic portal venous obstruction. If you notice carefully, there is a site of rupture on the side, on the last image on the bottom, and you see that the duct is dilated. It's got small cysts inside. So there is a chronicity going on. Next slide. So, Agri, how would you manage? You have four options here. Do you want to do a transpapillary stenting? Do you want to do a surgery? Do you want to put this child on nasojejunal feed and octreotide? Or do you want to wait and watch? Now, the options for you are transpapillary stenting. Next slide. So remember, Akwi, this is a patient who is 1 year of age only. My size of duodenoscope is going to be too big. And he's going to have a small papilla, and I have a risk of a pre-cut bleed because he has an EHPVO in the background. So he might have some biliary collaterals, some pericardial varices that may be cut inadvertently when I'm trying to do the pre-cut. The next option is surgery, Acqui, but the surgery, next slide, his albumin is just 2.5, so I don't know what's the best time for surgery. This child has a pancreatic ascites, he's just pouring out. And if you do a surgery at 1 year, assuming he has 80 years of life, he has another 79 years to go. So can you do a pancreatectomy in such a small child? And what pancreatectomy are you going to do? Are you just going to chop off the pancreas from the distal end? Nasojejunal feeding and octreotide, remember, a 1 year old is going to pull out the nasojejunal tube. We have compliance issues. And octreotide, we have side effects like bradycardia. And the last option, Akwi, is wait and watch, pray to God, and wait for the natural closure of disruption. So what's your thought on this, Akwi? What should we do?
I think we can start with prayer, and then I'll WhatsApp you, and then I'll call
Okay.
my local Peds GI, Dr. Amit Grover.
Okay, so what we want to do a transpapillary stenting in this patient, but the patient went into sepsis. So the option for us in the natural course was to just put a nasojejunal tube and octreotide. This child is still admitted in my ward. He's having he's doing better, but I can't say he's doing very well. So his output of the pancreatic ascites has come down. We're looking for a window to dare and do a transpapillary stenting. It's going to be a dare, definitely, because the size of the duodenoscope is just too big. Fortunately, we have an Olympus 140 series, which is a thinner scope, which has 11.8 millimeters diameter. And I think if we are careful enough with intubation, we should be able to do this case in the weeks to come. Next slide. So a little bit about post-ERCP pancreatitis. This is from my center, and we've shown that a difficult cannulation, more than 5 attempts, was associated with higher post-ERCP pancreatitis, both in the univariate and the multivariate analysis. But one of the other factors is also doing an endoscopic sphincterotomy. So now what we do is we give all our patient analgesia, either rectal or IV before the procedure, and we also make sure our patients at least has a 5 French stent after the procedure. Next slide. What's the yield of EUS in recurrent acute pancreatitis? This is one of our papers as well, where we've been able to show that if you do EUS in patients with recurrent acute pancreatitis, 30% of them already have chronic pancreatitis, early chronic pancreatitis changes. Next slide. The advantages of doing a transmural drainage is that EUS guided is that you do it under vision. You can look at an avascular area. You would be able to do in a non-bulging cyst where you have a small window of entry. And you can do it even if the cyst in the gut wall is more than 1 centimeter. In cases of coagulopathy, thrombocytopenia, sometimes you have gastric varices that are sitting there because of a splenic vein thrombosis. You could look at the debris and the septae and put your stent accordingly. And in adults, there is always a cystic neoplasm problem, so that becomes an important indication for EUS guided drainage. And unusual locations like the mediastinum, paroesophageal, and the liver hilum. Next slide. So this is an unpublished experience from my own unpublished experience. We've done about 193 EUS procedures in the last 7 years. 85% of them have had pancreatobiliary indication. We've been able to document 78% of our patients with acute recurrent pancreatitis to already have early changes of chronic pancreatitis. And actually, 30% have changed from acute recurrent to chronic in terms of the duct dilatation in 1 year of follow-up. The same patients have moved, 30% of them have moved to chronic pancreatitis, frank features of chronic pancreatitis. And we've also been able to do evaluation of the pseudocyst and the Waldorf necrosis. And about 12 of our cases, we've done US-guided gastrostomy. Next slide. Okay, very briefly, pancreatic trauma. The pancreas is overlying the spine and it's prone to injury, okay? So you can have compression or crush injuries. Next slide. Why children are more affected than adults is because of a thin mantle of fat that is there around the pancreas. There is increased flexibility and there is a resilience of the pediatric skeleton. So it allows external forces to be transmitted into the deeper structures. But unlike the bile duct, the main pancreatic duct is a rigid tubular structure which is surrounded by the pancreas. It has no place to move, so it is prone for disruption. Next slide. So next slide. So we have pancreatic injuries and we divide the pancreatic injuries actually on the level of the superior mesenteric vein and the superior mesenteric artery. And anything proximal and distal to that is pancreatic injuries, which would help us in decision making. Next slide. If you see the associated, next slide. If you see the associated problems, then most of the proximal injuries, 40% of them will have injuries to the liver and stomach as well. But if you look at the distal injuries, then the most prominent ones are the stomach and the spleen and possibly the left kidney. Next slide. So that makes the pancreatic trauma a very difficult scenario because you have other organs, solid organs that may be affected. But when you look at the pancreatic trauma, you have grade 1 and 2, which are minor contusions and some lacerations. What's important from an endoscopic point of view is 3 and 4. 5 is a massive disruption of the head, and you can't do much. You have to send the patient for surgery. But 3 and 4, 3 is a distal transection with a duct injury, and 4 is a proximal transection with a duct injury. Next slide. Okay, next slide. So how would you manage? 1 and 2, no problem, non-operative. It usually goes away in 10 days' time. But grade 3 is a distal duct problem. There's a controversy whether we should bridge it or not. Some of us in India want to bridge a grade 3 duct, but it's a distal duct, so you're going to struggle a lot. But grade 4, where the proximal duct is disrupted, you have to attempt an ERCP and bridging the duct, and you have to stent the duct as early as possible, because otherwise you're going to end up with a stricture. Next slide. This is one of our studies, and this is again one of the attendees is Dr. Athara, and she's published this nice paper on childhood pancreatic trauma in our center. And she's been able to show us in 36 cases that most of our patients required nasojejunal feed and octreotide. We've had to drain pseudocysts in 60%. What should be earlier done, whether we should drain or whether we should put the patients on TPA and octreotide, is a clinical call. There are no randomized trials that are going to address this issue, and it's always going to be a burning issue. Which step should have come earlier than the other? We've been able to do the duct bridging in some of the cases, and some of our patients have actually required surgery, and in the long run, 40% have developed chronic pancreatitis. Next slide. Very quickly, pancreatic insufficiency, chronic pancreatitis, fibrocalcific pancreatic diabetes is a problem of Asia. It's not a problem of North America, Europe, Africa. It's a problem of Asia. Why we have it, we don't know. Congenital syndromes, cystic fibrosis, Schwachman-Diamond, Johansen's blizzard, and Pearson syndrome are some of the other causes of pancreatic insufficiency. Next slide. So when you look at the CFTR mutation, the cystic fibrosis, you have the classical, you have the pancreas sufficient cystic fibrosis, where you have a severe disease, but you don't have much of pancreatitis. You have some of them having symptomatic pancreatitis. But as you go, as the pathology becomes less severe, then the chances of having a severe pancreatic insufficiency becomes lesser. And some of these patients only present as recurrent episodes of acute pancreatitis. Next slide. What's your diagnosis? Here is a 3-month-old baby. She has steatorrhea and absent ali nasi. That means she has no, this part of the nose, it's just not formed. The cartilage is not formed. And this is contributed by my friend Sumit Kumar. And this is a Johansson-Blizzard syndrome. It's a spotted diagnosis. Here's a 11-year-old boy. He's an orphan. He's been raised by his grandparents. And he has steatorrhea since 1 year of age. And if you look, he has some bony deformities as well. He's not thriving, he's short, and he has a cyclical neutropenia that's going on. Next slide. Okay, so we look at the pancreas. Can you see this black area? This is fatty infiltration. The fecal elastase is less than 200, and the genetics here is telling you the diagnosis. This is a Shwachman-Diamond syndrome, and this condition has a pancreatic involvement and also a lung involvement and also a bone involvement. Next slide. Okay. So the last slide here is a fibrocalcific pancreatic diabetes. We don't know why this occurs. They have diffuse calcification all throughout the pancreas. And it most commonly occurs in tropical countries, mostly the southern part of India. And they have pancreatic calculi X-ray on imaging. And one of the first cardinal presentations actually is the first time onset of diabetes, followed by the fact that they are discovered to have a pancreatic disease in the background. They have tried to show that there is a genetic mutation, but that's not a consistent finding in all the cases. So they've proposed a 2-hit model. They've said the first hit is a genetic mutation that has led to alteration in the pancreatic acinar cells. And the second hit is an unidentified gene, which we don't know what's happening, but that has led to a disease manifestation. So this is a complex, unknown, and unclear presentation. And these are the patients that would probably benefit from a total pancreectomy and an islet cell transplant. Next slide. So my final messages to you is we have rising global trend of acute pancreatitis. 35% of recurrent acute becomes chronic. That's not a very good number. Genetics has a strong predisposition with chronic, but it's not a consistent feature. So don't be upset if your genetics doesn't come positive, or don't be very happy that your genetics is showing you something that's taking you towards recurrent acute or chronic. ERCP is indicated for those patients with intractable pain, those who have stones, and if you have especially a proximal stricture. Distal or multiple strictures are not good for ERCP, and they would probably be candidates for surgery. Or if you have a stone that's sitting in a wide side branch, which you can't access through ERCP, are those patients who are going to move towards surgery. For complex anatomy, you need expertise, and the more complex it becomes, the more the chances you are going to end up with surgery in that case in the long run. EUS is having an increasing role in children, where we are reclassifying our patients into chronic from acute recurrent, where you can quantify the debris, where you can look at aneurysms, pseudoaneurysms up close if you're missing them on the CT, where you can do a guided drainage and very safe drainage. And I don't have experience, but in autoimmune pancreatitis, the biopsies are done EUS guided to look at the changes in the pancreas. Trauma in the pancreas is a very, very tricky situation because you have multiple other organs also that have trauma. So which one are you going to salvage first is very important. And there will be multiple steps when you have a trauma as a problem. So are you going to upfront do a surgery, or are you going to conservatively manage with nasovaginal feed, octreotide, stent the duct? It's that is something which I can't answer at this point of time. Next slide. So all of us who are here gathered today, we've come through a very long journey to become a gastroenterologist, and there's a lot of hustle that is there in our lives to be where we are right now. And what you spend years building one day may be destroyed overnight, but we have to go on working. We have to build it anyway. Thank you so much for your patient hearing. Akwi, back to you.
Oh, thank you. That was amazing. That really was. I love that last slide too. Very, very inspiring. Thank you so much. We do have some questions. Before we go to questions, I want to set the record straight about my capabilities in basketball. I just want to say my knees today are not the knees of med school. So no
So
one
that was
challenged me.
25 years.
No one challenged me to run because my mind says yes, but my knees are like, no, sit down. Um, anyway, thank you. That was super informative. So let's start with some questions in the chat, and then we'll look at the others. The first question is, how common is chronic calcific pancreatitis in children, and how do you use enzyme supplementation in them, and how long?
Oh, this is my teacher who's asking me this question. He's Dr. Puneet Mehrotra. He is a very renowned gastroenterologist here in Lucknow. I'm very happy he's listening to me. How common? We see a lot because we are a tertiary care center. We see a lot of chronic calcific pancreatitis in children, and we get about, if I'm not wrong, 4 to 5 new cases a month, and we've been stenting them years for years together because actually, to tell you the truth, in India, in lower socioeconomic countries, the we don't have a lot of liberty of spending a lot of money. Okay, so these patients don't have insurance. They can't afford an LPJ, a surgery. So it's easy to stent them, keep them happy, have less pain, unless they have a neurological problem, okay, if they have a wiring problem. How do you use enzyme supplements in them, and how long? How do you use is, for me, the patient who's not growing well, who has steatorrhea, or who has a fecal elastase that's positive, who is clearly showing a decline in the weight gain, in terms of weight gain. See, if you've gained about, say, 3 kgs in the last year, and this is a 10-year-old boy, and he's just gaining 1 kg in the next year, I would be suspicious whether he's going into a pancreatic insufficiency. So this is a group of patient I would like to use the enzyme supplements. For me, at that point of time, the fecal elastase doesn't matter. Also, for intractable pain, as a last resort, if my endotherapy is not working, my antioxidants, we try antioxidants as well. Maybe that's placebo, I don't know, but we do try pancreatic enzyme supplements in them. How long? Maybe forever, we can't say, because it's not something that you're going to get back with time. It's not like the liver, which is going to regenerate. This pancreatic insufficiency is just going to be there forever. Yeah.
And along those lines, in the children, for because we also use obviously in adults, but in the children, do you weight base it, and then do you do it 5 times, or what's the frequency? Because in the adults, we may say, like with your morning,
Uh,
you would breakfast, lunch, dinner, and then with your snacks in between, but it's
so
not
so
necessarily
that's
weight
a
based.
so that's a compromise there as well. Pancreatic enzyme supplements are very expensive in our country. They cost so they would cost probably what 35 rupees per tablet. So that would be about 30 cents for you per tablet.
Okay.
And if you had to give 4 of those tablets in one session, and we usually give it with the meals, 3 major meals, so that would cost them quite a lot on a daily basis. Now imagine a family having pancreatitis, where 2 brothers have genetic pancreatitis. That would increase the economic burden so much on the family. So we've got to be really careful. We have to weigh out finances versus palliation of pain or enzyme replacement. So we've got to really balance it out. On an average, we give about 25,000 international units per meal for a patient who is, say, 13, 14 years of age, adolescent, would probably give 25,000 to 30,000 international units per meal and three major meals. And in between, if he's eating snacks and he's really insufficient, we would probably give him a 10,000 international units, say, with the midday meal that he's having, the school, when he's in school, he's eating his break. So we'd probably give him an additional enzyme supplement there. But again, finances is a major problem in our country. Yes.
The next
And
question,
and and the demography in India, for some reason, Akwi, is that the poorer patients have chronic pancreatitis, okay? And the healthier patients, the ones who are obese, a little bit of money, have acute pancreatitis. And it's a horrible uh, difference in the strata of our society, where and the poor patients can't actually afford enzyme supplements or many sessions of endoscopy or surgeries. Yeah.
interesting. A question from the chat Q&A. Is cerebral edema a common complication of acute pancreatitis?
Cerebral edema. No, I haven't seen any,
Yeah.
but there is an acute encephalopathy that is mentioned with chronic pancreatitis, acute pancreatitis mostly. It's with the multi-organ failure, but I haven't seen cerebral edema. I can't remember cerebral edema. Sorry, I
Yeah.
won't be able to.
Yeah,
Sorry.
I haven't seen that as well in the adulthood, and I can't think of literature that describes that, at least in some of the common guidelines when we think of
There is a
complications.
retinopathy that is associated. 1% have a pernicious retinopathy, but I can't think of cerebral edema. No,
Okay.
sorry.
The next question, do you think that in the future, children with recurrent acute pancreatitis with CFTR mutations may benefit from drugs like
Yeah,
ivacaftor that correct the
absolutely.
anomaly?
So this is Atara who's asking me this lovely question. I think yes, Atara, you are on the right track. And that's one of the reasons in India we should be doing our genetic studies. We're not doing it enough. It was, how Akwi, we used to look at IBDs in the past, okay? We would just look at Crohn's and ulcerative colitis and say, okay, our job is done. We give them immunosuppressants and move on. But right now, even in adults, I hear younger adults also, they've started doing genetic testing in IBD because some of them have immune dysregulations, and you can probably target those immune dysregulations. So there's going to be a time in chronic and recurrent acute pancreatitis, that's not too far, where we will be having to do mandatory genetic testing in them because of two reasons. One is, as Dr. Athira mentions, that we probably can benefit from ivacaftor for the CFTR mutations. And the second thing is that we will be able to prognosticate if it's a PRSS or a SPINK mutation, the time at which these patients can develop the diabetes mellitus, and worse, some of them have pancreatic adenocarcinomas in the long run. So there is going to be a stage where we will be able to give them. And a recent study also from, I just showed you that study from American Journal of Gastroenterology, showed that the SPINK1 mutation patients are best benefited by the PERT therapy for having lesser progression for lesser episodes of recurrent acute pancreatitis. So these are going to be some messages that we will take in the years to come. So yes, genetics is going to be the main game changer in the long run. Yes.
There's another question about pancreatitis and cancer in children, like pancreatic cancer. In patients with chronic pancreatitis, and then maybe you can also define hereditary pancreatitis, do you screen for pancreatic cancer in children, or are you concerned about that, especially if they're very young?
No, I haven't seen any pancreatic cancers till date. And in children, I'm sorry, I haven't seen any till date. Maybe I have missed, but so far I've not had any case reports of the same.
Okay. And then the next question has to do once again with like the genes, are they and cancer? Are those with those different gene mutations that predispose to pancreatitis at higher risk of pancreatic cancer? So do you put them in a protocol or anything? Is there anything special to do with those children?
No, I'm not so I'm sorry, I couldn't understand the question. So
Yeah,
protocol
I think
for
it's about, I
screening?
think it's still about pancreatic cancer. You'd mentioned like the gene mutations in the patients with pancreatic or the pancreatitis.
Oh, okay. So,
That
oh yeah. So I guess if you have a genetic mutation, yeah. So that's one of the benefits of doing the genetics. If you have genetics, then you'd probably be more alarmed to screen them for pancreatic adenocarcinoma because this is one cancer that's really, really bad in adults, right? So we've in our family also lost quite a lot of family members with pancreatic adenocarcinoma, and once they start, they die in 4 to 6 months. So if you can pick up an adenoma, if you could pick it up in an adenoma stage, and probably you could get rid of that, and so that it doesn't progress to adenocarcinoma. But I'm sorry, I'm not the right person to answer this question. Maybe Akwi, you would be in a better position. Do you screen all your chronic pancreatitis? Let's say we take the knowledge from adults. Do you screen all your chronic pancreatitis for adenocarcinoma, like you would screen polyps?
no, mm-mm. No, I don't. It's usually those who are sort of at a higher risk, and the higher risk not only includes the genetic mutations, but also family history.
Okay.
The next question typed is rationality of antioxidants in acute recurrent pancreatitis and chronic panc versus
Okay.
chronic.
So this is my student and colleague as well. Um, to tell you the truth, there was this big hype, um, especially from the UK, followed by India, where actually we hit the wall when we look at chronic pancreatitis. You have nothing more to do other than stenting these individuals if you have a duct stricture stone. But what do you do with those patients who have a neuropathic pain? We don't know what to do with them. And they just go on having pain. And we've seen patients who, even after the surgery, a head coring, also have had a lot of pain. So, is there a way to palliate them other than a celiac plexus block? So, people tried to use antioxidants and they found grounds to use antioxidants. And they found a combination of a few things like lysine and vitamin C, vitamin E, and a few other chemicals, probably selenium as well. I'm not sure. They showed that these patients had lesser pain, lesser episodes of pain. In my practice, I feel, and it may be a placebo effect, though we've published some literature on this, we feel that yes, the number of pain episodes in a year may come down with the use of antioxidants before we try pancreatic enzyme therapies. But we're not very sure, there's no robust data to actually support the same with full, conviction that, oh yes, this works very well. The question that the Dr. Neetu is asking is that what is the rationality of using it in, so we have rationality for using it in acute recurrent, but what's the rationality in chronic pancreatitis? In chronic pancreatitis, if you have a type A pain versus a type B pain, then you'd probably use it in those chronic pancreatitis patients who have typically the episodic pains. The antioxidants may work in that subgroup, but those who have a persistent pain, they get up every day with pain and they sleep every day with the pain, nothing's going to work. You need to get rid of the pain center, you need to get rid of the celiac plexus at that point of time. So that, I think, that is the rationality.
Thank you. And there's another comment. Thank you so much from Dr. Arthia Ravindranath. So this is a good, she says, pancreatic encephalopathy can rarely occur in patients with severe acute
Yeah.
pancreatitis and can present with confusion and sometimes with coma. This may cause cerebral edema. And she put, I'm not sure if it's a she or he, but Dr. Ravindranath, he put in the comments with respect to the question on cerebral edema. Thank you very much. Yeah, this is part of the platform is we all can learn from each other.
Yeah.
Then the other question, or this is more of a point, the case you showed about, the pancreatic disruption, pancreatic leak, and in adults, usually we would place the stent first. We wouldn't, I mean, depending, there's other factors, but given that case, I'll be like stent first, and then, we kind of carry on.
Yeah.
Nutrition is always important in pancreatitis. We try to feed the patients by mouth as much as possible, because nutrition is part of the healing process. And then we've had cases where we've had to start octreotide as well, and surgery sort of quote unquote the last resort. At our institution, we actually have like a pancreatitis team that's primarily run by our surgeons, but we all work as a team. So they handle our complex pancreatitis cases. The question
Yeah.
I had, this is more me asking, is in terms of these little babies, because you mentioned like the 140 scopes that you use, and I trained with like when we did in smaller patients or patients with stenosis, we use the 140s, but those are not being made anymore. At least
Yeah.
in this end, so it's like you have a 140, you try and save it, whatever. But
Yeah.
and so now
So
we
we
use like
use
the
it.
Pentax. What do you do? What are you using now in the little babies?
Yeah, so we 140, we preserve it as much as possible. It's already
Yes.
10 years old, and
Yeah.
the company says, well, it's out of the warranty period, and we if it breaks, we can't do
Right.
anything about it. But it's one of those very useful scopes, and I'm surprised why they don't. Probably it doesn't sell too well, but then
Yeah.
it's uh, it's one of the okay. Prior to the 140, we also had a diagnostic ERCP scope, the thinner one. You know, the one that has 8 millimeter size. Okay, that
Yeah.
stopped. That Japan stopped making that totally. Then in replacement of that, we got that 140 scope. It really is very, very helpful.
Yeah.
Sometimes even what happens is even in an older patient,
Yeah.
you have an obstruction in D1. Have you noticed
Mhm.
that? You have a duodenal obstruction and you just can't negotiate your large scope through them. And you can do it with a thinner scope. So that's when the 140 works as well. So you
Yeah.
go through it and it's good for this. It's good for children who come with, we get a lot of choledochal cysts who come with cholangitis. And we could do, PTBD, but then we like to put in a stent and drain
Mhm.
them, the biliary stent.
Yeah.
And the patient I was just talking to you about who has a pancreatic leak, this is and pancreatic traumas. These are the patients who would benefit from this scope. So it's
Yeah.
really a very small proportion of patients, but then yeah, we should keep that preserved as much as possible. That scope.
Yeah.
Uh,
The smaller
I
scopes are restricted by
yeah,
the size of stent you can put through. That's the other challenge. So
yeah,
yeah.
yeah,
No, but thank you. Let me see. I think we've tackled all the questions. I think we've answered all the questions in the box. And let's see. Yeah, you've answered all the questions. So if there's any other questions, please feel free to type them in. But we have definitely gone over our time, time limit. And I just want to once again say a big, big thank you, Moinak. I truly, truly appreciate you. And I
so much.
appreciate your time and dedication. It was a lot of work. Those videos were great. I don't know. I think some GIs just looking at worms coming out of the bile duct will give you the shakes. But about that, are
Yeah,
you supposed to tug them out, or do you sort
yeah.
of just kind of would that anger them and make them, go in?
So you've got to tug them out. That day, tug them out as many as possible. Either you just drop them down,
Yeah,
okay? So they just slide down, or you pull them out. The risk of pulling them out
yeah,
is that if you lose them at the,
yeah,
you just go, they're going to enter the bronchial, they're going to enter the respiratory tract. So
yeah,
you don't want to do that. So, but then this is what can be done in ascariasis. In fact, there is a jet spray technique that they advocate. So they say chronic pancreatitis where there is pancreatic atrophy, and it's basically a dead, burnt out disease, dead duct. Okay, you have the biliary ascariasis, you have ascaris that goes into that, and sometimes you can't go all the way up to the tail of the pancreas, and some of them are lodged there. So what they do is they put the ERCP cannula inside as much as possible, and they just pump with water. They just spray. It's called a jet spray technique. They do it in, I don't know if you've heard of Kashmir. That is a place where we have a lot of ascariasis, and the gastroenterologists, the ERCP gastroenterologists, do the jet spray flush technique, and they try and get all the worms out of that, because nothing's going to work. Your Dormia basket, if you put inside, it's just
Yeah.
going to crush the worm.
Yeah.
Yeah, so you got to be really gentle
Mhm.
while you're pulling out the worms.
No
So
pill or
even your
anything? No
so
pill?
so sorry.
No pill? Can't give them a pill?
After the procedure is over, even the grasping forceps, I use the cupped ones. I don't use the ones with claws.
Yeah.
Yeah.
Okay. All right. Well, that was fascinating. Good way for us to end. So once again, thank you so much, and thank you to all those who came in attendance. Thank you for the questions. Once again, this is CME accredited program, so you do get points for attending this. This will be posted for those who are non-MGH. It'll be posted on hopefully YouTube if technology allows, and for those who are within the MGH system, you'll be able to get it within the regular route of how we post recordings. So thank you, everyone. Truly appreciate it. And a big thank you to both Angelo Atiak, who's on here, our medical student and our global health volunteer, and Dr. Kiza Brown, who's not here, but she's part of the team that worked behind the scenes to make today happen. And a big thank you to Michael Sweeney, who does our CMEs. Have a great day, Moinak. I'll see you on WhatsApp.
Bye-bye. Thank you so much. Thank
All right.
you. Thank
Take care. Take care, everyone. Have a great day. Good
you.
morning,
Bye-bye.
good afternoon,
Bye-bye.
good evening to you.
Bye-bye.
Ciao.